We're joined now for our second debate. This debate is going to be on lobar intraparenchymal hemorrhage, and I'm joined by my colleague, Dr. Jonathan Zhang. Dr. Jonathan Zhang and I started almost the same time here at Methodist 15 years ago, and he has risen to be the division head for cerebrovascular and endovascular neurosurgery, an excellent colleague always, and I welcome his perspective on surgical management of intraparenchymal hemorrhage. And my colleague, Dr. Kevin Immanuel, and Dr. Immanuel has been an outstanding addition to our neuro ICU, now the medical director of the neurological ICU, and will give us his perspective on the medical management of lobar intraparenchymal hemorrhage. So, Dr. Zhang, the floor is yours.
Well, thank you very much, Dr. Volpe, for the kind the invitation to participate in this wonderful program and the introduction. I want to start with discussing about the condition that we commonly encounter as neurosurgeons, stroke neurologists, the critical care physicians for the management. I don't have any relevant disclaimer for this talk. Intraparenchymal hemorrhage compromise a significant portion of the stroke care. Depending on the literature you review, up to 10 to 15% of the stroke is actually caused by intraparenchymal hemorrhage. And we are here primarily talking about the primary intraparenchymal hemorrhage. Most of the studies have shown that many of these are deep in location, which is common in basal ganglion thalamus, but up to about 1/3 of these hemorrhages can be lobar, and then a small percentage of these can be also located in cerebellum as well as in the brainstem. Unfortunately, when these hemorrhage occurs, it is devastating to the patient, and many of the researchers have shown that when these happen, and that they can have the mortalities up to near half of the patient at 1 month, and also they cause severe disabilities. And many of us working in the hospital in the ICU are very familiar with the ICH scores, and when the patient's hemorrhage is large enough, causing significant deficit or in certain locations, and also rupture into the ventricle and can cause severe disability, and the mortality of these are extremely high. Since 2007, American Heart Association and American Stroke Association has consistently putting out the guidelines. And in general, medical management is the mainstay. Obviously, one of the consensus is surgical management is really indicated for patients with significant cerebellum hematoma, and up to once it's more than 3 centimeters, and the treatment is typically with emergency surgery decompression to treat the brainstem compression as well as this hydrocephalus. There is really not that much of the evidence to support direct surgical treatment of primary intraparenchymal hemorrhage as the source of the intraparenchymal hematoma as in the supratentorial compartment as the benefits. Obviously, the opportunity arises when the hemorrhage occurred in the supratentorial compartment, particularly in the lobar hemorrhage. There is a cascade of molecular as well as the cellular levels damage from the initial first several hours to the 24 hours period that can actually leading to severe and consequential effects to the brain. And the main idea behind the surgical treatment is if we can arrest this cascade and somehow to provide the patient with benefits. In 2015, the guideline has been updated for additional evaluation, and as we can see, cerebellum decompression is still a high level of degree of certainties in the treatment. And in early treatment of the hematoma evacuation, many of the benefits is still suboptimal. And obviously, when a patient is clearly having neurological deterioration, surgical treatment can providing the life salvage in these circumstances. And as we can see, these are the class 2B, level C of the evidence. And lastly, decompressive hemicraniectomy without the hematoma evacuation. And from many of the studies for both head injuries, ischemic stroke with space-occupying lesions, as well as in the hematoma, that it certainly can help the patient to preserve life. And although we all have to realizing in all the caregivers involved that we may be able to pay the price by saving the life, but leading to severe disability. The modern newer technology of using very minimally invasive treatment to treat these patients, and with either endoscope or aspiration in combination of thrombolytic agents, is still under intense investigation, and the benefits is hard to say. And some of the classic surgical trials in the Stitch 1 and the Stitch 2 that comparing the surgical management with best medical management, unfortunately never has shown any obvious benefits, particularly if we're using the scales to measure the patient's functional outcome. And again, like I said, the craniectomy for providing the space for the herniating brain does actually can improve the patient's survival capability, but with significant disability may ensure. In Europe right now, there is a switch trial which is comparing the decompressive craniectomy versus best medical management for spontaneous supratentorial intraparenchymal hematoma evacuation is still ongoing, and we'll be eagerly awaiting for the results once it's completed the enrollment and the follow-up. More interestingly, over the last several years is the MISTY 1, 2, 3 trials that using very minimally invasive technology to treat both the deep-seated, the basal ganglion hemorrhage, as well as the lobar intraparenchymal hemorrhage. And again, despite using very, very minimally invasive technology, the treatment results is still not clearly beneficial, other than the some of the secondary measures that measuring the hematoma evacuation does show the benefits. This is the MISTY 3 is which probably is the most relevant, that comparing treating the supratentorial spontaneous intraparenchymal hematoma, that using very minimally invasive technology and comparing to the standard of medical care. And again, even though the mortality into the treatment arm is into the surgical treatment arm is less, the long-term endpoint is the good functional outcome is still difficult to establish, that showing the benefits of the surgery. And the important trials, these has shown that the surgery, the other way you can look at it is the surgery fortunately does not cause additional harm compared to the best medical management, and that's why it's important to work with a multidisciplinary approach with our stroke neurology team, the critical care team, as well as neurosurgery team, to identify the patient that potentially can most beneficially, can most benefit from the surgical intervention, so that we actually can achieve the best results. Some of these novel idea, in addition to the stereotactic aspiration of the hematoma, is using really minimal invasive surgical port to get into the hematoma and then removing the hematoma more successfully. This is on the left side is the enriched trial, which using the brain path tools to evacuate the hematoma and using exoscope, and on the right side is using the penumbra surgical hematoma evacuation while inside of the endoscope, which I have done several of these, and these are actually really promising technology, truly promising the minimal disruption to the normal brain. And these are several of the ongoing Enrich, Invest, Pronto trials, all using really very slick technology. And they are ongoing, and with the surgical trial, hopefully these will show some of the promising benefits. And the key is, in order to clear the threshold that we can actually accomplish the functional outcome benefits, is still a very high road. But hopefully with some of these larger trials, and we can identify the subgroup of the patient that can most benefit from these minimally invasive surgical treatment, so that we actually can help the patient that has relatively good neurological baseline but has a high risk of deterioration. With surgical intervention, we actually can help these patients and promptly. And with that, and we will talk about some of the future directions in addition to using the surgery to help, is try to identify the patient that may actually can benefit with combination of better neural protections and better methods that we can provide into the ICU settings. And in the long run, we can give them, identify these patients earlier so that we can intervene and providing the best care for them. Thank you very much.
Thank you, Dr. Zhang. I can't help but ask you one question, if you don't mind. That you really started a very insightful talk. You started off by telling us how severe this disease is. And much of the studies have used our outcome measurement of things like modified Rankin score, and that scoring comes from ischemic stroke, which may have a larger, outcome, less severe outcomes in some cases. Is one of the issues maybe that we're measuring in a crowded modified Rankin of really 3 to 5, that those are the outcomes that we're realistically targeting more often than not, and it's just not enough space to see the differences in these patients? Or is it that other measures of outcomes like quality of life, or Dr. Burton talked about depressive scales and mood disorders, are we measuring the right outcomes in these studies? I
actually feel like this is the same kind of questions we were discussing quite a bit before the trials for the modern thrombectomy, and we were discussing about whether using the modified Rankin scales to measure the outcome of ischemic stroke treatment. And somehow we may be able to enter into the same stage. And granted that treating hemorrhagic stroke, particularly with patients, many of them, and actually is the neurological extremists, and it is a much more challenging. But I'm remaining hopeful, even though it's a really high uphill battle, that somehow along the way we will find in the surgery realm our thrombectomy tools and the stent retriever, the proverbial, or the catheter, that we actually can have a breakthrough in surgical technology that actually can make a big difference. But on the other hand, I really welcome any of these new tools, new ideas that we can finally evaluate the patient, that actually can hopefully identify the benefits more in terms of intervention, whether from medical standpoint or from surgical standpoint, that actually can have a more meaningful yardstick that we can use.
Wonderful, thank you. Well, Dr. Immanuel, you have medical management. Give us your perspective on the right way to manage these patients.
Thank you, Dr. Volpe, and thank you, Dr. Zhang. All right, my name is Kevin Immanuel. I am going to be talking about medical management, which really is the mainstay at this point for lobar hemorrhage. I do not have any disclosures. So Dr. Zhang already went through really what we're talking about, which is intracranial hemorrhage, non-traumatic. And we've talked a little bit about primary ICH, particularly in cases, most of these are going to be hypertensive, which are usually the deep, as well as amyloid angiopathy, which represents almost half of the lobar hemorrhages, which is really what we're kind of discussing here. And And of course, I'm going to talk a little bit about some secondary causes. But just for primary ICH, typically you have more in the subcortical tissue, deep tissue, as opposed to the lobar hemorrhages. Now, lobar hemorrhages, the incidence typically will increase in age, but in this day and age where we're using more and more anticoagulants, we are seeing more incidence of intracranial hemorrhage. All right, so we talked a little bit about primary etiologies, which mostly is going to be, especially in our elderly patients, amyloid angiopathy, and some, for completion's sake, some additional secondary etiologies, which is where a lot of our surgical techniques may actually be beneficial in managing things like AVMs, for example. So this is just the 2015 guidelines for management of ICH, which most of it really kind of spells out some of the things that Dr. Zhang mentioned, particularly for infratentorial hemorrhage. So let's talk a little bit about what amyloid angiopathy. As I mentioned, it's going to be mostly prevalent in our elderly patients. So to kind of paint the picture, we're discussing an 80-year-old who has probably some coordinative impairment, as well as possibly some microbleeds in the past, who now presents with a lobar hemorrhage. How do you manage that patient? And a lot of these patients, as Dr. Volpe was elucidating too, the kind of measuring them by MRS may not necessarily be the best method because a lot of these patients may already have some additional comorbidities that are kind of inhibiting their functional as well as their cognitive status. But the primary underlying pathology for cerebral amyloid angiopathy is really the recurrent deposition of amyloid into the arterial walls to impair the integrity of the walls. So it's a lot different than a high pressure system where the vessel ruptures. And also, as I mentioned, you can see a lot of this also kind of crossover with a lot of our patients having not just Alzheimer's dementia, but also vascular disease and dementia as well. One of the unique things that occurs, especially in patients with amyloid angiopathy, is really kind of the higher risk of rehemorrhage. In some patients, in some papers, it's been quoted to be about 25% higher, with about a 12% increase on a yearly basis. So really kind of managing the risk of rehemorrhage is an important part of the treatment. This is really just to show you the modified Boston criteria for diagnosing amyloid angiopathy. All right, so I labeled this slide contributors to poor outcomes in our patients, and I'm just going to state some of the things that we see when a patient really becomes symptomatic, ends up in the ED, and then rapidly deteriorates. Hematoma expansion, mass effects. These are a lot of where the surgical trials have kind of really been focused on. Intraventricular extension, mostly with really deep intracranial bleeds, but also perihematoma cerebral edema, the inflammatory cascade that happens not just in the brain, but also systemically. And of course, hemoglobin toxicity itself. And as I mentioned, anticoagulation, effective rapid reversal is very key. Some additional systemic contributors to these patients, hypoxia, because what happens in a lot of these patients is a rapid decrease in the patient's level of consciousness, their ability to protect their airway, their ability to breathe by themselves. So a lot of these patients will end up getting intubated, but a lot of these systemic things do contribute to the patient's overall poor outcomes. Things like patients having cardio and hemodynamic instability. In some studies, there's actually been reports of patients' troponin being elevated, being associated with worse outcomes in these patients. So stress itself is not something that's just limited to the brain. Glucose management, one of the class 1 level C recommendations is really to avoid the extremes of glucose control. Same thing with fevers. Fevers in these patients is something that needs to be managed. Now, the hypothermia studies that have been done so far don't really confer any benefit, but preventing fevers is something that's very, very valuable in these patients. Same with metabolic as well as electrolyte derangements. And management of seizures, which I'll talk a little bit about a little bit later. These are kind of the focus of preventing really secondary brain injury, even if we are unable to prevent the primary insult. Hematoma expansion, as we mentioned, is one of the reasons why our patients deteriorate fairly rapidly. We see this probably more in our patients who have deep ICH than lobar hemorrhages, but depending on the size, the growth of the hematoma actually is an independent determinant to both functional outcome, which is extremely important, as well as mortality. Hematoma expansion, even in some studies, have been quoted to be even higher than 50%. And a lot of this, which is the very interesting part, will usually happen in about 24 hours, which most of them happen within the first 6 hours. And by the time you kind of get beyond 8 hours, you start seeing less and less rapid rates of expansion. So treating these patients, identifying them right from the onset is key, which is why employing medical strategies is an extremely important part of managing these patients, even if these patients end up having surgical interventions, which I'll talk a little bit about later. But one of the things that really struck me in the INTERACT 1 trial was for every 1 ml of expansion of hematoma, increasing that volume actually confers a 5% increase of death and disability. And as Dr. Zhang pointed out, the amount of disability and as well as mortality that we see in our ICH patients, although they represent a smaller subset of the stroke, is rather significant. So you need strategies really to prevent hematoma expansion that need to be deployed early, and they need to be dynamic, which means that there needs to be somebody who is actively focused on these patients before they rapidly deteriorate. So I'm just going to briefly talk about some of medical strategies. The heart of our medical management is really hypertension, managing blood pressure. Yes, most lobar hemorrhages are going to be from etiologies such as cerebral angiopathy. However, the growth of these hematomas really enhanced by elevated blood pressure, even if that's not the underlying etiology. And untreated hypertension really has been associated with poor functional outcome. One of the other important parts too is that a lot of these patients, even if blood pressure is not the primary etiology, will come in and have headaches, they may have pain, they may have anxiety. So managing all of these things really help in lowering the blood pressure and keeping it at a steady state. Now, there have been quite a few studies that have been done. Some of them I'm going to talk about, the INTERACT 2 as well as INTERACT 2 trials, where we're really focused on lowering the blood pressure. Now, a lot of these studies have been deemed negative studies, but one thing that I do want to point out is that lowering blood pressure does work. It does impair the patients from deteriorating compared to the alternative, which is not controlling blood pressure. The challenges that we've had is the target blood pressure, or the range, or the rate, or the choice of antihypertensives. And what I would say about that is really you use what you're comfortable with. My preference is to use drips because I get a steady state, because one of the things that I suspect is impairing some of the outcomes that we're seeing is really blood pressure variability. I already talked a little bit about making sure that these patients are well taken care of, especially their pain, which can contribute to their elevated blood pressure, or the difficulty in managing their blood pressure. Now, reversal of anticoagulation is something that I mentioned is also important. So these are just 2 studies, which I'm going to talk about briefly. Really, what they were comparing was doing aggressive management, intensive care less than 140 compared to 180. Yes, they may not really be a significant difference as far as mortality and disability rate between the two, But blood pressure still remains one of the building blocks for really managing these patients' populations. And I want to kind of point out a little bit that if you look at some of these studies compared to what's been shown in the natural history based on some papers that were written in the 80s, you really see that there is a difference between the rate of patients who are actually experiencing hematoma expansion compared to when blood pressure was not really the mainstay treatment. All right. There was also some post-hoc analysis that really kind of showed that there was improvement with every decrease in systolic blood pressure. You actually get a 10% increase in functional improvements. That's kind of what the odds ratio showed. Another way of saying it is really if the patient starts having additional increase in the systolic blood pressure, there is a potential that these patients could deteriorate just from the increased size of the hematoma. Now, optimizing blood pressure targets, like I mentioned, is still unclear, but it's reasonable to keep these patients' blood pressure less than 160. Targeting less than 140, as we saw in the ATRACT-2 trial, really just showed that there was some renal injury without really conferring any additional benefits. Now, reversal of anticoagulation is going to be specific really to the anticoagulant that you use, and this is really just for your reference, especially with the introduction of the NOACs. So hematoma expansion, really surgical. Dr. Zhang talked a lot about this with the STITCH trials as well as the minimal invasive, so I'm not going to spend too much time. But one of the things that I did want to point out is, as I mentioned, really a lot of the patient's deterioration and increase in hematoma size happens pretty ultra early, typically in about the first 8 hours. And a lot of the surgical interventions really rely on hematoma stasis, which means that the size does not change before they actually intervene, which is probably why we're not seeing a lot of the improvements that we kind of expected. So my pitch was essentially medical management is to really prevent and it's more proactive rather than surgical intervention, which is more of a reactive kind of phase. But it is needed as we really see a lot of disability in these patients. All right, so the role of surgery, in my opinion, is really to save lives. It may not have any functional improvement, but in a patient who's rapidly deteriorating with a huge mass effect, decompressive hemicrania is going to save their lives, and quality of life questions are really something that is family dependent, and those are things that the provider really kind of talks to the family and helps with that. One other thing that I would like to mention as well is the use of scores. A lot of times we use these scores, especially early on, as a predictive way of prognosticating, kind of telling the family what the mortality, for example, may be in 30 days. And I usually caution my fellows, residents, because sometimes these become a self-fulfilling prophecy. But truly, the management of ICH has to be in a very collaborative, multidisciplinary way within a high-volume center with dedicated intensivists, neurosurgeons, interventionalists, ancillary staff. Those are really what I have seen make a big difference in the patient's overall input. Long-term outcomes, a lot of these patients really just need time compared to our ischemic stroke patients. For some of them, even as much as 12 months. So those are things that I really caution our families, because there's quite a bit that happens between the time the patient is stabilized in the ICU and when their eventual recovery process. And like I said, a lot happens: airway, aspiration risk, optimizing nutrition, which is a very important part, and also managing complications such as strokes, VTEs, and physical and occupational therapy. All these things play a role in patients' eventual outcome. Thank you.
Thank you, Dr. Immanuel. An excellent endorsement of medical management. Let's just assume for a moment that we don't get the functional outcomes. You know, you're an ICU director. Your ICU is full most of the time. You deal with bed issues, and you know how valuable those resources are. What if these studies were to simply show a decreased length of stay in the neurological ICU, or a decreased cost to the system of a patient's disease in that front-end hospital stay? Is that good enough for a treatment to be adopted, or do we need to see what we're all looking for as functional outcomes?
That is certainly an aspect that's very important, because it's not just managing the patients and doing everything that you have to do. One of the things that we focus on, at least here at Methodist, is really to bring value. And that value can be measured in different ways. It could be cost, it could be length of stay, certainly. It could be really helping these families kind of transition to whatever end. In some cases, it may be, really kind of honoring what the patient may have wanted, because a lot of these patients, especially with lobar hemorrhages, are advanced in their age. But these are important things that really we kind of evaluate on a case-by-case basis. But yes, I think that those are important points.
Surrogate outcomes, great. Well, thank you all. Now for the cases, and in a moment we'll hear our rebuttals, and I'll introduce those discussants in just a moment. But the cases are here. So this is a 68-year-old man with a history of hypertension, smoking, presents with an acute aphasia, fall. His blood pressure is elevated, 190/100. INR is normal, platelets 155. On exam, he's lethargic. He has a mild right droop, otherwise intact. He has a motor left 5 out of 5, right 4 out of 5. His NIH is modest, 6, and his GCS is somewhat impaired at 12. And this is the imaging, so a rather large left frontal hematoma. We'll come back to that for your poll response after the next rebuttal. This is the second case. This is a 59-year-old man with a history of cirrhosis, and he's had a progressive left arm weakness and a slight headache and nausea. His blood pressure is normal, 108/75. On his exam, he's alert. His speech is slow but dysarthric. Cranial nerves are intact. On the left, he's hemiplegic, and on the right, 4 out of 5. INR is 1.5, platelets 56, so the effects of cirrhosis. And his NIH is 16, and his GCS is deteriorated to 8. And this is a CT that illustrates much of what Dr. Immanuel was just discussing. We see the primary hematoma in the more hyperdense region, and then maybe some hematoma expansion in that rim posterior to the original hematoma. So a patient who's really deteriorating before our eyes. So these are the cases, and with that, I'll introduce the rebuttals. First will be Dr. Nguyen. Dr. Nguyen is the program director for our critical care fellowship and has served as a neurointensivist in our neurological ICU. And Dr. Daniels is a neurosurgery resident who is a critical care fellow with Dr. Nguyen. So I hope, Dr. Daniels, if you win the debate today, that your program director is not too upset. And I will turn it over to Dr. Nguyen to kick us off.
Thank you for having us, Dr. Volpe, and more importantly, thank you for hosting this as well. That was a great talk by both Dr. Immanuel and Dr. Zhang. I wanted to just give my 2 cents before going through the cases. So yes, this is going to be a multidisciplinary approach. Of course, we need identifying the bleed right away. When the patient comes into the emergency department physicians identifying which patients likely to have a stroke, and then of course with the CAT scan being punctual, being quick with this, to identifying which patients have bleeds, and of course consulting the appropriate services as well. We're lucky being at Methodist that we have all these things, and our team is second to none, I believe, with this. And I just wanted to make that statement before going and looking at the cases. So can we look at that first case again? So I'll take this first part, and Dr. Daniels, I think you can chime in on this, the second one as well. So what we see here is, of course, a very large left frontal ICH. We see with the red arrows here, we see this self-Faucian herniation as well. And it's a little bit hard to tell on this, but the green arrow, let's say that that's a little IVH as well for discussion purposes. So there's the yellow arrow dictates kind of the edema, the perilesional edema that we see with this. So this is a very massive bleed. From the HPI, I believe the GCS was around a 12 on this. So this goes back to looking at grading scales as well. So if we were to believe the ICH score, this is an ICH score of 2. The GCS was 12, so you get 1 point for that. And for intensive purposes, that bleed, let's say if it's 30 cc's, that's another one. And again, if we call this IVH, then it will actually be 3 on this. So this is a point of contention. This ICH score, of course, we're just how to communicate amongst us. It should not be used to tell the patient's family, hey, this is after 30 days, there's a 72% mortality. But in this case, the 68-year-old man only has a history of hypertension as far as we know. He's not on any other medications as far as we know, doesn't have a history of underlying coagulopathy, doesn't have malignancy. And prior to this, it seemed like he was doing fine. So besides the medical management, getting his blood pressure down, making sure that the hematoma doesn't expand, correcting all the other underlying things, I think this patient may benefit from hematoma evacuation. In the cases that were discussed by both Dr. Zhang and Dr. Immanuel, a lot of the trials using minimal invasive surgery, although they haven't come clear in terms of showing a positive endpoint just yet, I think there's going to be something there. And I think this patient, if we don't do anything and just maximal medical management with hyperosmolar therapy, it probably will not be enough for this gentleman. So I'll pause and I'll see what Dr. Daniels has to say.
Yes, so first of all, thank you for having me and including me in this debate. So I agree with Dr. Nguyen. You know, this patient at his baseline, relatively sort of healthy, no major comorbid medical conditions. The only thing that would maybe dissuade us from taking him to the operating room is this is a left frontal bleed. It's on the left side. And so his performance score, months from now may be severely affected just because of that. But given his, his age, his other comorbidities, his favorable coagulopathic profile, and his exam with just kind of that minimal right-sided weakness that seems like there's a lot to save there as opposed to our other case, which was completely paretic on that side. I think that it is reasonable to take this gentleman to the OR. Also, the location of the bleed being less than or about a centimeter from the cortical surface is favorable for a corticectomy and evacuation of that bleed. So.
Great. Well, moving to the second case, Dr. Nguyen, do you want to give us a perspective on this patient?
Yes. So for this, the HPI states that he has an underlying history of cirrhosis. And what's key is also his weakness is progressive as well. And when we look at the scan, and I think you alluded to this, there's a little bit of a difference in contrast, in difference in the hematoma hyperdensity. You can see the posteriorly, it's a little less hyper dense there. So when we see a picture like this, we suspect that, hey, this bleeding, generally a patient has some kind of underlying coagulopathy, which makes sense with his history of cirrhosis. For this case, yes, the hematoma definitely has a high chance of expanding, and this is where medical management comes in. This is where we make sure coags are obtained in a timely manner. This is when we make sure we give products, we reverse anything that we can with this. In a patient that's cirrhotic, you can imagine their INR, all their factors generally will be low as well. So making sure we replenish some of these things to prevent the hematoma expansion is the most important thing. In this case, though, I feel like taking this patient to the operating room would be a very difficult decision and something that I would not promote or suggest. The idea here is that the bleeding and to obtain hemostasis in these patients is going to be very difficult. And I think even in the operating room, opening this patient up, even for a cranie, a lot of times you can't stop the bleeding that will occur. And so for that reason, though, this patient I would manage medically.
So for this patient, there's a little bit more difficulty here kind of with our decision making, just because, as Dr. Volpe alluded to, it is a progressively enlarging bleed. It seems like he is kind of actively deteriorating, but the reality is his comorbidities, his baseline status with the cirrhosis and this coagulopathy, from kind of my experience and operating with my attendings, even if you correct these coagulopathies and these thrombocytopenias with product and with platelets and you get the numbers absolutely perfect, these patients will still bleed just because of it's sort of unquantifiable bleeding risk that you kind of encounter in the OR. Many times taking a cirrhotic to the OR is just disaster waiting to happen. So I think that probably for this gentleman, max medical management, and ultimately, if that's not successful, then palliative care may be appropriate. He is kind of young, so obviously max medical management would be the preferable thing here to prevent that bleed from expanding.
Thank you. I want to go back to the first case for just a moment and bring in Dr. Zhang as well for a moment and say that, when we see this case where a patient maybe was brought in straight from home, the ictus was maybe an hour or so from when we were approaching the patient in the ER. There was, I believe, an ultra early study. I think Morgenstern's group out of Michigan did one within 4 hours, and they actually saw that the patients who had ultra early surgery had rebleeds. Maybe there's a perihematoma coagulopathy at those cases. With a case like this, if you're going to take the patient to the OR, what's the Goldilocks time? What's your thought process on how to approach the timing of surgery?
That's actually, if I know the answers to these questions, I will probably be in a much better places. I think that's some of the ongoing active researches and in many places that we are trying to identify what's actually the Goldilocks time. In addition to what you mentioned, that some of the studies that show that ultra early intervention may improve the patient's outcome, there are some of the studies that show that ultra early intervention and will be followed with hematoma re-expansion and all these. I think the only consistent results we get so far is once beyond the 48 hours from the ictus of the hemorrhage. Then surgical intervention is frequently not associated with good results. In terms of the ultra early, I think the jury is still out, and we're still trying to identify the best patient. But bearing in mind that many of these intraparenchymal hemorrhage, especially lobar hemorrhage, is a very heterogeneous group. There are many different underlying pathologies and the comorbidities, and that can influence many of the factors. So I just have to be evasive, and I don't know exactly the best answers to this. But for patient like this particular here that we presented, there is some favorable factors associated with surgery, and especially by presumably that much of his deficit is probably caused from the edema in the laterally, which is associated with the eloquent cortex. So if we can remove the hematoma from medial aspect of the hematoma, avoiding more eloquent area, decompress the brain, and achieving good hemostasis, there is, at least in theory, there is a good chance we can actually, in both the short term and the long term, to help the patient.
And Dr. Immanuel and Dr. Nguyen, I'll just bring back to the second case. This gentleman has an intrinsic coagulopathy, and we've seen maybe in the FAST trial, and then Dr. Broderick alluded to the fastest, which is going to be an additional study of factor 7, reversing this coagulopathy. Also, it has been an area of controversy. Dr. Immanuel, you want to tell us first any of your perspective on how you might medically manage the coagulopathy?
It's particularly for the cirrhotic patients, I typically like the TEG because that gives me a little bit more information as to the patient's underlying coagulopathy beyond just the INR. However, typically for cirrhotic patients, even when you correct those factors, these are patients that typically bleed. So I agree that there's really not a surgical option for these patients, but the goal would be to be as aggressive as possible in correcting the underlying coagulopathy. Like I said, I like using tags, as well as giving platelets. That's still a little bit controversial, but typically for these patients, I would like a certain threshold, typically above 100,000 if that's possible, and manage their blood pressure as best as we can, because most of the time, although I want the patients to do well, preserving their function and preserving what they currently have sometimes is the goal.
Great. And Dr. Nguyen, I know you're the epileptologist in the NICU. As you look at both, maybe this patient in particular having a temporal lobe hemorrhage, what do you think? Is this a patient you would prophylactically start on an anticonvulsant, and if so, why?
Yeah, so for all comers, generally it's discouraged to start someone on seizure medications. We talk about the subcortical hemorrhages, of course. Generally, we do not do that here. This second case, as you pointed out, brings up a good case, though. It's temporal lobe. And in this case, though, there's such of a high incidence of seizures with these patients. Not every location has continuous EEG like we do. So in this case, in these temporal cases, though, I do actually propose starting anti-seizure medications for that reason. Great.
Well, thank you all for a wonderful debate. I will just say that I'll let the audience now have their say. So with the first case, you've heard our discussants actually come to some consensus. So you can put in your poll response now, and we'll give about a minute for that. And for the second case, you can enter that as well in the poll and just let us know if it was the first or the second that you're giving your response for. And we'll allow those to continue while we go to break, and we'll be back with our next session after this. Thank you all.